Hi, this is Sheba from WeTalkScience.com. This is the first podcast that I am doing with my good friend Andrej Spec, which I met on Twitter. Andre, hi. It's very, very nice to talk to you.
It's wonderful to hear you too.
Brilliant. So tell me all about yourself, Andre. First of all, I want to know what you do and what you're interested in.
So, I am an infectious disease physician who specializes in fungal infections, not the toenail kind, but rather the invasive, deadly, highly destructive fungal infections that predominantly happen in immunocompromised patients, but also happen in some people who are immunocompetent. And I do um, mostly research, but I do also have a very active clinical practice to helping take care of patients with those diseases.
Okay, so you mentioned that you're looking at fungal infections in immunocompromised as well as immunocompetent patients. I'm just curious, what is the percentage of people that you treat that are compromised versus the ones that are competent?
So that's a really interesting question. So, you know, the argument is usually that most people, even those who are immunocompetent, have some level of immunocompromise that we don't know about. So it might be simple genetic deficiencies, or in some diseases, it can be as little as diabetes that can predispose you to a devastating fungal infection. But I would say, if you think of the classical immunosuppressed patient, that would account for about 80 to 85% of my patients.
Okay, that's really interesting because I have, in fact, read that, if you are immunocompetent, you don't have that much, to be afraid of. But if you, of course, have had a, major surgery, or if you have HIV, for example, or you've had a long illness that leaves you immunocompromised, those are the patients that are usually most in danger. So could you tell me a little bit more about the immunocompromised patients, first of all? What are the kind of infections do you see?
So we break down the fungal infections in the medical world into three groups. One is yeasts. The second one is what we call dimorphic molds, and the other ones are the classic molds. So the classic molds are the kind of things that grow on your bread. Uh, they tend to be more involved in highly immunosuppressed patients. And it's because when your immune system is almost completely gone, the mold doesn't tend to know you differently from bread. So it tends to just start to try to decompose you, and there's no immune system to stop the mold. However, the other ones are the dimorphics, and the yeasts are the ones that I tend to see most of. And those are both the Candida infections, which cause the infamous thrush, but they can also cause invasive blood infections, to things like Cryptococcus and diseases like histoplasmosis and blastomycosis, coccidioidomycosis, which are diseases that, where I'm from, are relatively common out in the States, but in Europe are very, very rare and only really seen as being imported by people who have traveled elsewhere. So the bulk of the treatment is usually with either surgical, if there are pockets of infection that need to be cut out, or with antifungal therapies, of which, our biggest workhorse for the seriously ill is still amphotericin B, which got a new packaging and a much more uh, palatable formulation in 2002, but it actually dates back to the 1950s.
Okay, very cool. So let me go back to a little bit about the dimorphic moles that you just spoke about. Why is it that it is rare in Europe and so common in the States? Is there a reason for that at all?
The majority of their life cycle is actually spent outside of us. The They live as a mold in the environment where they feed on vegetative matter, nitrogen-rich feces, old carcasses of animals, things like that. And then they form tiny little spores, which, or technically they're called conidia, which are then inhaled, and then they set up an infection in us. And because of our body temperature, they convert into a yeast. And why Europe happens to be spared is the honest question today is I don't know. The histo, for example, which is the disease that I work with a lot clinically, likes areas with long, muddy, slow rivers. And so lots of diseases around the Mississippi. There's lots of disease around the Yangtze, a lot of disease around the Ganges, Amazon, all the areas where there's a lot of slow moving rivers. And so if you think about the southern Danube down in the Balkans, there should be some disease there, but there just doesn't happen to be. And why Europe happens to be spared, where histo, for example, is found on every other continent other than Antarctica, I don't know.
Well, how do you, so here's a completely, ignorant question. Infection does also depend on the genetics of the host as well, right?
Mm-hmm.
In usual cases. Do you reckon that there is something genetically different about the populations in Europe that is not, might be different from the ones from the population of the United States, perhaps?
The largely the populations genetically have a lot of crossover.
Hmm.
And for certain diseases, for example, coccidioidomycosis, people of European descent are actually somewhat protected, whereas people of African descent and people who have, especially the Filipino descent, are actually very highly at risk. However, people of European descent get disease if they live in America,
That's
and if
interesting.
they, but people of high risk African descent or Filipino descent don't get it if they live in Europe. And coccidioidomycosis specifically is probably never going to be seen in Europe unless global warming really goes out of control, um, because it's associated with deserts. So that one is really associated with the San Joaquin Valley, Arizona, around Las Vegas, and into California's Bakersfield.
That is really interesting, Andre. Okay. Going back to your practice, so you see these patients every day. What is the prognosis of these patients? So first of all, let's go back one step though. Let's talk about diagnosis. From what I have heard in various conferences, one of the biggest hurdles in fungal infection is actually diagnosis. Probably not so much in the United States, but it's probably more in the third world countries where diagnostics are actually a little bit less developed or available. So how do you deal with diagnostics? And please, I would like to hear the basics of this. And further on, I want to talk about prognosis and probably also about mortality rate. So diagnostics first of all.
Sure. So diagnostics are a challenge. For some diseases, we actually have pretty good tests. So cryptococcosis happens to be a disease where we have a pretty simple test that's actually very inexpensive. Here, the reimbursement rate for it is about $17 per test, whereas I think commercially it's available for less than $5 in the third world. And it actually has, especially in the high risk populations, a sensitivity and specificity in the high 90s. So that disease we actually have a pretty good test for. But the problem with most of these diseases, which it's totally true that most of them don't have as good of a level of testing as cryptococcosis, is that they are a test you have to think of to order. And that's what makes it hard. So if you compare this to a common disease that is easy to diagnose and we don't tend to miss it very often if somebody's in care, such as diabetes, if you order a routine panel, you'll be completely aware of diabetes, it'll pop up and kind of shout at you that that's the diagnosis. Or if you're thinking of a bacterial infection and you have somebody who's pretty sick, like a blood infection of a bacteria, the blood cultures will have a high predictive value of being able to be detected. However, these routine tests that we do, almost by rote, uh, are very bad at detecting fungus. So the real problem with fungus is, yes, the testing is not as good as it should be, but the biggest problem is that people don't think of it before it before it's very late in the game. And to put that in perspective, we're currently doing a study that we haven't published the data on, but I can share a little bit with you, which is from about 10 different states in the United States. We collected administrative data on patients who were diagnosed with Cryptococcus. And then we looked at 90 days previously to look at, did they get admitted to the hospital with a disease that looked like it could have been Cryptococcus, but were diagnosed with something else. And approximately 50% had a previous admission. So not just went to see their GP or their primary care doctor in the office and were told this is nothing, don't worry about it, but actually were admitted to a hospital and were given a different diagnosis and then discharged, only to come back and have this be diagnosed with Cryptococcus. And ends up being about 40% of people go through that process before they're diagnosed. And what's actually even worse is that those who actually have an admission where they're missed and discharged and then get readmitted again with a new diagnosis of Cryptococcus actually have a significantly higher mortality.
What kind of mortality are we talking about?
So Cryptococcus mortality varies depending on your immune system. So if you have HIV or your solid organ transplant in the Western world, your 90-day mortality is about 15 to 20%.
Wow.
However, if your immune system is normal, or you fall into the category of other immunosuppression other than those two, your mortality can be as high as 30%. And if you're cirrhotic, your mortality with Cryptococcus, a 90-day mortality, so we're talking very short-term mortality, is up to 80-85%.
Okay. Wow. That's very high. Um, all right. So if I understand it correctly, a lot of fungal infections are actually not caught early enough because people, doctors are not entirely certain of what to look for because they're running all the rote tests that doesn't actually show you what the problem is. Is that correct?
Yeah, that's a big part of it.
All right. So how do you see this changing? How do you see this getting better? What would you recommend, that doctors should, what do you wish that doctors would do in addition to what they're already doing in order to look at fungal infections? I mean, do you reckon that there are standard tests that they should be running for a certain set of symptoms? What do you think the future should look like?
I think a big part of the way the future should look like is we in the mycology field need to move away from the rare disease discussion. We always talk about fungus being rare, and a lot of us got into it because it's kind of rare, so it allows us to be to do something really cool, something really difficult. Um, but in reality, the data currently is suggesting that fungus, at least worldwide, is actually an incredibly high burden of disease, uh, contributes to a high burden of disease. And to pick on Cryptococcus, for example, it is now responsible for more deaths worldwide than tuberculosis. And if you go to Latin America, histoplasmosis is now responsible for more deaths specifically in that area than tuberculosis. And as the rates of TB and HIV deaths are going down across the world, fungus is still staying important. And to then go into the resource wealthy areas, in the United States, there was an article, I think about 3 years ago, 2015 or so, that looked at nosocomial infections, so infections inside the hospital. And the number one bloodstream infection, so blood sepsis, was from Canada, a yeast. And until we move away from the it's a rare disease, we will not be catching it as often as we should. So simple tests, like I talked about the Cryptococcus one, we it's cheaper than the routine blood testing that we do on every single patient who comes into the hospital. So my argument is that, to pick on that one, anybody who has anything that can even remotely look like Cryptococcus would be worthy of getting that kind of a test. Because even if you pick it up 1 in 500 times, it would be cost effective.
Really interesting. So, I mean, doctors at this moment in time know how to diagnose a bacterial infection versus a viral infection, for example. Is there something very, very common? What I'm trying to ask you is there a common symptom that all fungal infections have that doctors can immediately pinpoint to a fungal infection?
Absolutely not. And that's actually part of what makes fungus so complicated. And many of these fungi have such different presentations that I've seen for histoplasmosis 100 different ways that it's presented. And it's very common for me to see patients which have been given a diagnosis of another disease. And they actually, especially for rheumatologic diseases, they actually fit the criteria for those diseases. And they've been treated for them for 3-4 years and getting worse and worse and worse. And it's not until we diagnose the fungus that we can actually help them move forward. But if there was a simple symptom that kind of push things forward inside the brain, that would be wonderful. The best thing I can say, and the thing I say to a lot of people I work with that I try to teach, is that always be skeptical of the atypical presentation of any disease. So if you see that this person is diagnosed, let's pick a rheumatologic disease that I've seen present as fungus, adult Still's disease. Normally that responds pretty well to therapy. However, if you're done 3 or 4 different regimens into the therapy and patients still getting worse, a pretty strong suggestion of that would be that this is no longer adult Still's disease. And so this can be, a short term kind of a thing, somebody who's not getting better with quote unquote bacterial sepsis, and then 2 to 3 days they're not getting better, then it's time to consider fungus. As well as long term people who are dwindling with these long chronic infections. So it's about keeping it in the forefront all the time. And then it's also about getting the experts involved. So always thinking that there's somebody that an infectious disease physician, especially an infectious disease physician specializing in fungus, has to add to a disease. Even if you haven't diagnosed it yet, we can evaluate, we can look at it, we can discuss, and we're always happy to be of assistance.
Wow, that seems to be incredible. I mean, the problem seems to be very, very complicated, of course. Um, so let's talk now about if, well, fungal infections are blamed for things that actually don't exist, or at least are misdiagnosed. So when we had a conversation earlier about some of the misdiagnosis of fungal infections. Do you want to tell us a little bit more about that? Probably it's a frustrating point for you, I suppose.
It's a lot less frustrating for me than it is for the patients. So a common disease that gets referred to me well, two common diseases that get referred to me are the what's often referred to as the candidal overgrowth syndrome, and then the other one is often is referred to as the sick building syndrome. So the candidal overgrowth syndrome is often blamed for a lot of very non-specific symptoms, gastrointestinal problems, bloating, tiredness, fatigue, itchy skin, dry skin, overly moist skin, just a lot of very non-specific syndromes. And similar thing happens with the sick building syndrome. And the two are very different, but those are diseases that I often see patients for. And I rarely, if ever, have much to help other than to kind of end some of the things that have been done to them.
So basically, you are eliminating a diagnosis, is what you're saying.
A lot of times, especially if we talk about the candle overgrowth syndrome, it's often treated with uh, things that people take and the specific ways that they clean their skin, and they're often taking antifungals to try to eradicate candida from their body. And they also have very, very, very restrictive diets that in some of the more extreme cases actually make it almost impossible to live in the modern world. And so and then some physicians and some practitioners will actually do cultures from body sites, and they will say, your culture was positive for Candida, therefore you have Candida overgrowth syndrome. But if you swab 100 people walking down the street in 5 sites, 99 will be positive, at least one site. That's because Candida just lives on us. And it does not cause disease if it's in the right place, in the right numbers. So if it grows too much, it can cause things like diaper rash, or like the vaginal candidal infections, or thrush that people get in their mouths, especially associated with antibiotics, because they compete with bacteria for their living space. And if you kill off the bacteria, they just grow. And so if they get too much of them, they can cause problems. Or if they get into places where they're not supposed to be, like the blood, they can cause problems. But in most people who get given this diagnosis, there is another reason why they feel bad. It's important not to discount their experience and their suffering, but it's not the Candida.
Fair enough. Fair enough. So, in the last few minutes, if you had one important message to say to the people who are listening, what would that be?
Fungus is complex. We are inundated with it all the time. Molds and other fungi are so pervasive that they're literally part of every breath we take, like the police song. Um, and some of them also live on us, and they live in us. And the problem is incredibly complex. So if you think that you have a problem with fungi, it's important to talk to somebody who has experience with it, and to understand that sometimes a positive culture or something we read on the internet isn't always true.
Wow, that's a strong message. Thank you very much, Andre, for your time. This was very, very interesting, and I hope that our listeners have had a good idea now about fungal infections and how we should not discount them, just as a rare disease, but happening more often than we realize.
Thank you.
Thank you very much, Andre, again, and thank you to our listeners for listening. And we will talk to you again very, very soon.
You have a lovely day.